It is now with great pleasure that I introduce our president and founder, Ms. Anne-Marie Minghon.
Good afternoon, ladies and gentlemen, and a special warm welcome to our colleagues from the Mona and Keyville campuses, as well as our specially invited guests. I acknowledge our advisory board member, Dr. Alfredo Walker, High Court Judge of Trinidad and Tobago, Justice Katia Waterman Latru, and staff and students of the University of Ottawa and Eastern Ontario Regional Laboratory Association. Thank you for joining us for the 5th installment of our Caribbean Pathology and Laboratory Medicine Student Initiative. But before we begin, I would just like to invite Dr. Alfredo Walker to say a few words.
Hi, good afternoon, everyone. All protocols adhered to. Welcome to the 5th Caribbean Pathology and Laboratory Medicine Student Initiative. You guys are in for a treat. You have a fantastic speaker, in none other than Edwin Nkengla, who is one of our histotechnologists here at the University of Ottawa. So I hand it back for Edwin to be formally introduced.
Thank you, Dr. Walker, and it is now with great pleasure that I introduce the chair of this afternoon's session, Ms. Gia Francis.
Hi again, everyone. At this time, ladies and gentlemen, I am tasked, yet privileged, to be introducing our featured speaker this afternoon, Mr. Edwin Nkengla. He will be sharing his wealth of experience and passion for pathology in a 60-minute overview of cytopathology, specifically the Pap smear and cervical screening. But before we begin, I would like to give you all a brief background about Mr. Nkengla. Mr. Edwin Nkengla is a native of Anglophone Cameroon, where he obtained a bachelor's degree with honors in medical laboratory sciences from the University of Buea. He later completed his postgraduate studies at the University of Wolverhampton, United Kingdom, where he completed a master's degree in Biomedical Sciences. Mr. Nkengla trained and served as a biomedical scientist in the United Kingdom, where he worked at the Birmingham Heartlands Hospital in the Midlands and later at the Conquest Hospital, East Sussex, United Kingdom. He migrated to Canada in 2011, where he now lives with his beautiful family. He stands firm as a believer in Christ and also serves as an elder at his local church. Mr. Nkengla is a strong advocate for medical laboratory sciences and serves as a competence assessor for the provincial regulatory body of the College of Medical Laboratory Technologists of Ontario. He presently works at the Eastern Ontario Regional Laboratory Association as a histologist. He has an interest in cervical cancers, with his most recent study being the detection of mutations in the TERC and CMYC genes among cervical lesions using fluorescent in situ hybridization techniques, also known as FISH. Without a doubt, Mr. Edwin Nkengla stands humbly and proud as a pioneer in the field of biomedical and laboratory sciences, as well as in cytopathology. We are honored, pleasured, and privileged for him to be here with us this afternoon. And so, ladies and gentlemen, I ask you to welcome Mr. Edwin Nkengla.
Thank you, Gia, and thank you, Dr. Walker. Thank you, Anne, Mary, for this opportunity and privilege. After such a great introduction, there's not much I can say, but I'm humbled. So I'll share my screen now. Before we start, I want to welcome everyone to this great session and wonderful initiative. It's such an honor to partake in this journey. So this evening, I'll be talking on the Pap smear and cervical screening. And basically, we'll be looking at, let me take the screen away. Basically, we'll be looking at what the Pap smear is all about and its role it plays in cervical screening, which we'll find out how important it is. So my objectives for tonight are to provide an overview of a Pap smear. I'll be looking at the clinical, the laboratory, as well as the pathological perspectives of a Pap smear and the importance of a Pap smear in cervical screening. And we'll look at some screening guidelines we have out here in Ontario. So what is a Pap smear? So a Pap smear, also known as a Pap test, is a procedure we use to screen for the presence of precancerous as well as cancerous lesions in the cervix. This test is credited to the Greek physician, Dr. George Papanikolaou, who invented the technique, although there's some rumor around this invention that he had a colleague named Babes who also participated somehow. So it involves the sampling and smearing of cervical smears from the ectocervic and the endocervic onto a slide that is later stained using the Pap Stain. So since we're talking about the structures of the cervix, I thought we should look at a brief anatomy of the cervix. So the cervix, as we all know, is part of the female reproductive system, and it's located within the vaginal cavity. It's made distinctly of two main parts, the endocervic, which is the canal leading to the uterine cavity, as well as the ectocervix, which is the external surface which faces the vagina. The endocervix is distinct in that it's lined with columnar epithelial, which produces mucus, and whereas the ectocervix is lined with squamous epithelium, as we shall see when we start looking at smears. There's one very important point between the endocervix and the ectocervix, and that is where they meet. The area where the endocervix and the ectocervix meet is known as a squamocolumnar junction, a name that was deduced based on the differences in epithelial types. And that area is very important because that's the area where a lot of transformation occurs, and that's the area where the clinician will look for to collect specimens for their smears. So that area is also known as a transformation zone. And this transformation zones change over the year of the females. And the reason for that is that when the female is still very young, the transformation zone turns to be inward within the canal, right next to the os of the cervix, which is the little entry point of the cervix. And once the female grows older and over time has had a few babies, the transformation zone moves outwards And as you can see from the diagram I have right here, it talks of the original transformation zone that used to be inside has moved outward. And now we have a new transformation zone closer to the os. The area between the old and new transformation zones is what is known as the area between the old and new squamous columnar junctions, I beg my pardon, is what is known as a transformation zone. And that's where we'll always want to collect specimens from, because a lot of metaplasia and pre-malignancies, as well as malignancies, develop in that area. So what is a Pap examination? Once a patient has gone into the hospital to be looked after, maybe because they've had a few symptoms show up, or they've become sexually active. So there are a few risk factors that could contribute to a patient needing to have a Pap exam. And a few of them are things like once you become sexually active, or maybe if there's a positive for HPV, or maybe you've been using a lot of contraceptives, or you have multiple sex partners and stuff like that. All those events will predispose you to easily have some cervical abnormalities. And that's why you require a Pap exam. And once you go into the clinicians to have a Pap exam, like the picture I have right here on the right, the clinician will have to examine the cervix. And they use what is called as like a speculum to open up the vaginal wall so they can expose the cervix, as we see right here. And using one of the various collection swabs or spatulas, the clinician will be able to collect cells from the cervix. Now, we have a few types, and there's a reason for this. The reason for this is that, as I mentioned in the previous slides, we want to go for the transformation zone, the area where metaplasia will easily occur. And in a younger female who hasn't had any babies, that transformation zone is usually found within the endocervical canal. So if you use an air spatula, you will be collecting a little bit of cells in the endocervical canal and more of the cells in the external endocervical canal. And you may not actually sample the transformation zone in that young female. Whereas in an older female, using an air spatula would be a great choice, because that allows you to sample the transformation zone, which has moved outwards over time with the delivery of babies and other activities. So like right here, we have a demonstration of the air spatula in the collection of cells for the Pap smear. And as you can see, it does go into the endocervical canal a little bit, and the 360 turn around the endocervical surface allows it to collect the metaplastic cells, which will be found in the transformation zone, as well as squamous cells and columnar cells that are found lining the endocervical canal. So that would be a good choice for a more elderly female. For a younger female whose transformation zone will basically lie within the endocervical canal, the tool of choice will be the Cytobrush. And the reason for that is that the Cytobrush is tiny enough to be inserted into the os and then into the endocervical canal. And you just need to rotate it at 180 degrees to collect enough samples that will be needed for your Pap stain. Here we have what we call the Cervical Brush, and this is a great invention because it collects both samples from both the endocervical canal as well as the ectocervix with the brush, the broom tips, which you can see on the side, and you can rotate a few times to collect as many cells as you need. So this will sample your cervix pretty well. So prior to latest techniques, which was basically after sampling the cervix, the collection tool was used to create a smear on a slide. And the smear, after the smear was created, the slide was placed in a fixative or sprayed with a fixative to keep the cells from getting destroyed or drying and getting them ready for staining. So this technique has issues because, one, it covers the entire area of the slides, and two, it's not that easy to read under the microscope because you have a lot of background staining and you have cells all over the place. So the conventional staining techniques that were used in the past are not the best for today. So what has replaced them with time? So what we have now is the liquid-based cytology techniques. And what the liquid-based cytology techniques do is once the collection is done, like we've seen in our previous slides, the tip of the collection tool is then placed in a preservative solution that also acts as a fixative. And this also helps to lyse red blood cells and mucus cells that will create all the background staining that we found in a conventional technique. So this is very important because then it allows the cytotech or the cytopathologists to be able to read the slides and easily identify what they're trying to look for without having to struggle with a lot of background staining or with overlaying cells. So the two main types of liquid-based cytological techniques we have are the short path technique and the thin prep technique. And basically what these techniques do is that they allow the development or the production of a thin monolayer of cells that are distributed on the slide and making it easy to be stained and viewed in a 20 millimeter diameter. For the short path technique, the fixative and preservative of choice is ethanol, and for the thin prep, it's methanol. So the thin prep technique basically uses, once the tool is rinsed in the preservative solution, it uses instruments that will use a suction technique to pull all the cells in the solution onto a film, a membrane. And once the membrane is full, the membrane will deposit the cells onto a slide, and then the slide will be ready for staining. As we can see on the right-hand side, we have 20 millimeters in diameter cell deposits ready for staining with Pap Stain. This is very good because we do not have to view the entire slide area, but just the 20 millimeter diameter. So we see the difference from the conventional technique, how clear the Pap Stain slides are. We can easily identify our cells of choice, and we do not have the background staining that we had in the previous slides. So those are the advantages that come with a liquid-based cytology. And what this is also giving room to is that it has also allowed for technological advancements in the ability to be engineers to create scanners that can then read slides, because now the cells are evenly distributed and there's not much background staining. So these scanners have algorithms that can read the slides and then easily tell us which ones have malignant looking cells and which ones do not. So it kind of narrowed down the work for the cytotechs and the cytopathologists. So here we have just a comparison of the two methods and the advantage of the thin prep Pap smear or Pap test method over the conventional, as we discussed in the previous slides. You can see only a fraction of collected sample is used because you can't smear all the cells you collected, whereas in the thin prep, you rinse the entire cell collections in the vial, and once there's sponge, you you have a good chunk of cells to look at, and you also have cells preserved so that you can reproduce your slides if need be. In this situation, there's no way of reproducing the slides. Excuse me. So if we look at the pathological representations of a Pap smear after we've performed a Pap stain. So if I could talk a little bit about the Pap stain. A Pap stain is the stain that was invented by George Papanicolaou. And what this stain allows us is the ability to be able to stain the various cells that are found in the cervix based on their developmental stages. And the stain constitutes actually 3 different stains. It has Harris hematoxylin as one of the component stains. And what the hematoxylin does is stains the nuclei of the cells dark blue. The stain also constitutes the orange G6 stain, which, and the next one is the EA36 or EA50 stain that stains the other cytoplasmic components. So on this image, we can see normal cervical cells that we find in the cervix. On the top left, we have the superficial squamous cells with the pink-looking cytoplasm and centrally located nuclei. On the right top, we have intermediate squamous cells that are still developing and moving up. As we can see, they're staining greenish blue because they're still under development, and their nuclei is a little bit larger compared to those of the superficial squamous cells. On the bottom left corner, we have parabasal cells, which are cells from the basal basement membrane of the cervix, and they're developing. This parabasal cells do develop into the intermediate squamous cells, and the basal cells are our basement membrane cells. So here we can appreciate where in our cervical, in the cervix, where the various cells lie, and our basal cells at the very bottom, parabasal cells at the very bottom. And as we move up, as the cells develop and become keratinized squamous epithelial cells in the superficial level. So we, in this slide, we can see the normal slides at the top, where we have our squamous, superficial squamous epithelial cells with a nice tiny nuclei and pink keratinized cytoplasms. But when we look at the bottom, we have a high-grade squamous interstitial lesions on the left bottom right here. And what you can see is that they basically look like basal cells finding themselves at the top. And this is looked at as a malignancy because cells of this nature should not be found on the superficial surface of your cervix, because this can only happen if there's rapid proliferation happening within the cervix. And so that will call for a closer examination in colposcopy. On the top left, we can also see this is an abnormal slide of showing abnormal cells, but this is of a low grade. So here we have here we can appreciate the gradings that have been done as we look at the various slides in cytopathology. The escus basically is atypical squamous cells of undetermined significance. And here we have low squamous interepithelial lesions As we can see, we have a few normal superficial squamous cells mixed in within the abnormal looking squamous cells and the high-grade squamous intraepithelial lesion, which we saw in our previous slide, where you see there's mostly absence of any superficial and mostly basal looking like cells. We can see the enlarged nuclei and the reduced nuclei cytoplasmic ratio, which are very determinant factors of malignancy. So once you've had an abnormal Pap test, the next step is you get moved for a colposcopy examination. And what the colposcopy examination is looking to ascertain is to find out whereabout on the cervix is the abnormality found, and that will also aid in the treatment or the surgical removal of the abnormal zone. So in the images, you can see an image of a colposcope, and it's just shining a bright light onto the cervix with the aid of a speculum. And the colposcopist also uses some staining techniques to identify the areas of interest. So we have the acetic acid technique, which will stain the areas of interest, will stain whitish, because normally the ectocervix is rich in glycogen, and once there's an abnormality present, the abnormal areas become lose the glycogen in the cells, and for that reason they turn to stain white, the aceto white. This will then give the colposcopist an idea of what areas to sample for biopsies. We also have the Lugol's iodine technique to stain the cervix, and actually the Lugol's iodine works the other way around, whereby the absence of staining will signify abnormality. So because if there is an absence of staining, it means that the iodine is not being taken up by the glycogen-rich cells, meaning that area has an abnormality and it should be sampled or it should be biopsied. So, SIN1 cervical intraepithelial neoplasias are known as low-grade cervical intraepithelial neoplasias because, as you can see on the image on the left-hand side, we have quite a good amount of squamous cells still present on our epithelial surface, and we can see the infiltrating basal-looking cells moving up towards the superficial epithelium. Whereas when you look at the CIN2, which is CIN2 and CIN3s are classified under the high-grade cervical intraepithelial neoplasias, you can see clearly from the images that we have lost a good amount of squamous cells in the CIN2, and there's almost little or no squamous cells left, as well as in CIN3, there's absolutely no squamous cells left, and the entire epithelial thickness is full of basal-looking malignant cells. So this clearly shows us the progression of the classifications that are being done, and this will also be used to correlate the cytoprep or the cytology Pap test that was performed, as we saw in our previous slides. So like I said, it'll be injustice for me to talk about cervical screening without mentioning screening for high-risk HPV, because cervical screening is basically done to reduce or catch cervical cancers at an early stage when we still have the precancerous lesions. And one of the greatest etiological factors or causative agents to cervical cancers are the high-risk HPVs. And we found out that the HPV 16 strains cause 55% of the HPV infections, and the HPV 18 causes 16% of the HPV cervical cancer infections. And we have a little cocktail of other strains of HPV that will cause about 20% of the cervical cancers or abnormalities that we see. So in Ontario, we have our screening guidelines for cervical cancers or for cervical screening. And what it's basically recommended out here is that once a woman or a lady at age 21 becomes sexually active, then it's time for her to start having a cervical Pap test, Pap test or Pap screening in order to 3 years after, in order to prevent any precancerous lesions from progressing. And then if a woman is at 21 is not sexually active, she should actually delay her screening until the time when she becomes sexually active. But this doesn't mean that she may not be sexually active, but maybe she participates in other risk factors like I mentioned earlier, like douching and the use of other external objects that could cause abrasions to the cervix will also constitute a sexual activity, and so those aspects will also be regarded as sexual activity, and she will be encouraged to get a Pap test. So if you have an HPV status negative, then you are recommended to wait for 3 years prior to getting your next Pap test. But if you have a positive HPV, after going through your colposcopic examinations and doing another Pap to find out if the treatment options that were done was successful, you then are recommended to do a Pap test annually just to make sure there is no recurrence. And we have an unknown HPV status where it's recommended to follow the advice of the colposcopist. This is just a management scheme of how to manage the various abnormalities that could ensue from a Pap test. So like we saw the ASCIS grading. So if you have typical squamous cells of undetermined significance, then you should repeat the cytology in 6 months. If you have a normal test, repeat again in 6 months. And if it's still normal, then you do a routine screening after 3 years. However, if you still have an ASCIS diagnosis, then you should do another colposcopy. And if it's still diagnosed as atypical squamous cells of undetermined significance, then you have to still have another colposcopy until that is dealt with. We can see for women who are greater than 30 years old that the HPV testing for the oncogenic strains, which we saw in the previous slides, will be encouraged. And if it's negative, then we go back to the 3-year interval. And if it's positive, then we have the colposcopic visits, just like we saw in our previous slides. If it's unknown, you have to repeat the cytology in 6 months. For low-grade squamous cell interstitial lesions, it's almost the same recommendations, where the cytology is repeated in 6 months until we have 2 normal results. And if we have still atypical or another low grade, then we have more colposcopic visits to address those matters. So that's it from me, and I want to thank you all for listening, and the floor is open for questions.
Thank you, Mr. Nkengla. At this time, we'll take any questions. You can feel free to either unmute your mic or send them any chat, and we'll have Mr. Nkengla answer them for you. Just giving about a few more seconds to give chance for anyone who'd like to ask any questions.
Hi, that was a great presentation. Thank you so much. I'm just wondering if it's if we're able to see any benefit to having young females in high school in Ontario have the HPV shot in high school.
The vaccination question always pops up when you talk about cervical screening, doesn't it? So some governments around the world have instituted the shots as a preventive measure, but it's not yet been taken as a recommendation in Ontario, but I believe it's something that will be considered in the future. However, I don't sit on that position to make such a call. But I think if you look in the UK, in the United Kingdom, they have instituted that approach of prevention of giving young females the HPV vaccines to prevent them from getting infected with the virus, and thus preventing the occurrence of the precancerous lesions, which could then progress to cancers. Thank you.
Justice Latcher is just asking if you could show the last slide again, please.
Okay, one moment. Is it that one?
Yes, I believe it's this one.
Yeah.
Would you like Mr. Nkengla to go over it, or would you? It's okay for you to just have a look, Justice Lachu.
If you could go over it, that would be good. It's a little small, so I wasn't able to follow everything.
Okay, thank you very much.
Thank you.
So do you want me to go over this slide?
Yes,
I would
please.
appreciate it.
Okay. So on the left side, we have the diagnosis of our various Pap test lesions, as we just saw in our previous slides. So if we have a diagnosis of an atypical squamous cell of undetermined significance as a diagnosis from a Pap test, for women less than 30 years old, you are recommended to repeat your cytology Pap test in 6 months. If you have 2 subsequent normal test results, then you are recommended to do a routine screening in 3 years. However, if after you repeat your cytology Pap test in 6 months and your results still come forth as atypical squamous cells of undetermined significance, then you are recommended to proceed with more colposcopic visits until you have a normal result. And then you require to have 2 subsequent normal results again within a 6-month interval before you will be recommended to do a routine screening after 3 years. And that's a recommendation for women less than 30 years old. For women who are older than 30 years, you will be required to do an HPV test for the oncogenic strains, which we saw in our previous slides. If you have a negative HPV test, you will then be required or recommended to do a routine Pap screening test in 3 years. If you do have a positive HPV test, then you'll be recommended to have a colposcopic visit. And we saw what a colposcopic visit entails in our previous slides. However, if the HPV status is not known, then a cytology Pap test is recommended in 6 months. If the test result is normal, just like we had on the first instant, you'll be required to have 2 normal test results within a 6-month intervals, and then you'll be recommended to go to have a 3-year interval before getting another Pap test. But if you have a result of a typical cells of undetermined significance again, you will be recommended to go through another colposcopic visit to address the abnormality. Excuse me. For the low-grade squamous intraepithelial lesions, if you have a low-grade intraepithelial lesion diagnosis, then you will be recommended to repeat your cytology Pap test in 6 months. If the results are normal, you'll be required to do another Pap test in 6 months and obtain another normal test before you'll be recommended to wait an interval of 3 years prior to the next Pap test. However, if your results have a diagnosis of a typical squamous cells of undetermined significance, then you have to proceed with colposcopic examinations again. Sorry, I lost my screen there. So for benign endometrial cells on Pap tests, premenopausal women who are symptomatic require no action. Some screening for women older than 65 is not recommended. I think in some countries it's up to 70. But if the diagnosis is benign, then there is no recommendation for premenopausal women who are symptomatic require no action for premenopausal women. Postmenopausal women require investigation, including adequate endometrial tissue sampling. And abnormal vaginal bleeding in any woman requires investigation, which should include adequate endometrial tissue sampling, just like we saw in our previous slides.
Thank you.
You're welcome.
I have 2 questions from Mosia as well. She's asking, what is the recommended timing of Pap smear with regards to the menstrual cycle, and or pregnancy?
So for the menstrual cycle, it's recommended to wait 2 weeks after you have your menstrual cycle before you come for a Pap test. And that's because you do not want to have a lot of bleeding still present around the cervix during a Pap test. So it's recommended to have a 2 weeks interval before you go for a Pap test. What was the other question?
With regards to pregnancy as well.
With regards to pregnancy, to have a Pap test?
Yes. The recommended timing after pregnancy.
Oh, after pregnancy. I'm not too sure about that one.
Thank you.
I'll have to look.
Okay. And one more question. At what age does cervical screening end in Ontario?
after 65 years of age.
Okay, thank you very much. So we received some excellent feedback from your session. I'll just share my screen so that I can show you some of the feedback we received.
Hi, Anne-Marie, we have one more question.
We have one more question, sure.
Yeah. The question was, let me just get it. Yes. How routine is HPV testing for females in Ontario or Canada?
How routine?
Yes, how routine are the testing?
I think I had a slide. So it's not routine based on a planned nature. Like what we saw in our previous slides is, it depends if you're sexually active. Once you're sexually active, you are recommended to have a Pap test. And that is recommended from age 21. And after you've had a negative Pap test, then you're recommended to have another Pap test after 3 years. Does that answer the question? So basically every 3 years, if you have a negative Pap test.
Hi, good afternoon. This is Gary Collins here. I was the one who asked the question because I came in a little late. Excellent presentation, by the way. When do you do, I mean, is the HPV testing done routinely with the Pap? Because I'm trying to remember how it's done. And so is it done as part of the Pap smear on a routine basis?
Not at all. So it depends. So sometimes you have a co-test on individuals that are above 30 years of age. You have a co-test where you do an HPV as well as a Pap test. But for individuals less than 30 years of age, it's usually just the Pap test.
Now, so when would you decide if you're going to do the HPV testing?
If you have a positive Pap test, so if you have a Pap test that shows abnormalities, then you want to do an HPV to find out if the HPV is the causative agent or it's something else. Because we have to understand that HPV is one of the causative agents, but it's not the only causative agent. Other risk factors like smoking can cause cervical cancers, as well as we have genetic mutations. Like I had a study which I worked on where we looked at genetic mutations that predispose patients to have cervical cancers. So those could be other factors that could be looked at after you've narrowed down or excluded the presence of HPV in the patient.
Now, when you come across the low-grade type HPVs, do you let the patients know as well, or do you just inform them if they're positive only for the high grade?
I do not actually personally release results on this, but I will expect that every result should be delivered to the patient, whether low grade or high grade.
Thank you very much.
You're welcome.
I also saw the hand of Mrs. Henry earlier. Ms. Fernanda. Henry, do you have a question you wanted to ask?
Yes, I do. Thank you. I joined the presentation late, but it was wow, it was an excellent presentation. Thank you so much. I have two questions. One about what sort of treatment is available for cervical cancer, and secondly, if you can share a bit about the vaccine, the age that it is recommended, because I see it being advertised to kids between about 12 and 15 years old, and so I'm just, because I have children, so I'm interested in understanding the vaccine and its efficacy and so on. Thank you.
Thank you very much. So the first question about the treatment. So normally the treatment options will be during your colposcopic examination. After the colposcopist can identify the area of abnormalities, then they will use what they call surgical excision techniques, like they use a loop, wired loop excision technique to remove the area of abnormality from the patient, which would then be sent to the histology lab for further examination. And then the patient then will have another Pap test done 6 months after that, just to make sure that that area of abnormality has been taken care of and there's no recurrence or no area that was missed. So that will be more of the direction of treatment that will be done when, or hysterectomy, complete removal of the cervix. It will be another option if the cancer or the malignancy is found to be invasive and it's going more to all the deeper areas of the tissues. So a complete hysterectomy will prevent that cancer from proceeding or becoming metastatic. On the aspect of the vaccines, vaccine administration is more of a public health assignment or duty. So I do not, like I said, for Canada, it's not something which has been instituted yet, but I know that countries like the United Kingdom, it's something that's is done more on a government level, where they decide based on their public health committees what age is appropriate for females to receive the vaccine, and then they make up programs to encourage people to take them.
Okay, understood. Thank you.
Thank you very much.
I'm seeing one more question as well. We have someone asking the relationship between a yeast infection and Pap smear results. Does it cause irregular Pap smear results?
So you can, I know you can find Candida on a Pap test, but I wouldn't expect it to cause irregular Pap test results. I'm not sure of that, but yes, you can find Candida on a Pap test.
So if I could just jump in here.
Yes.
Yeah, Candida, actinomyces, they do not initiate any cytological changes in the cells at the transitional zone. So you will see them as organisms on your Pap smear, but they would not be associated with any of the cytological changes of SYN1, SYN2, or SYN3.
Thank you very much.
Thank you, Dr. Walker.
Are there any more questions? We'll just wait a few seconds for anyone who'd like to ask any more questions. Okay, so I believe we've completed our question and answer segment. I just have a little bit of feedback from our participants. They said that your session was very informative, understandable, interesting, well explained, and they very much enjoyed it. So we want to again, thank you very much for your time. And I'll now hand you back over to Gia, and she'll give you the votes of thanks for this evening.
All right. So ladies and gentlemen, it is with great pleasure that I now present the vote of thanks for today's proceedings. So Louis Pasteur once said that science knows no country because knowledge belongs to humanity, and it is the torch which illuminates the world. Firstly, I'd like to thank our featured speaker, Mr. Edwin Nkengla, who graced us this afternoon with an amazing and enlightening presentation, where we were all extremely grateful to learn about cytopathology, specifically the Pap smear and cervical screening. We would also like to extend our gratitude to our advisory board member, Dr. Alfredo Walker, who was privileged enough to grace us with his presence this afternoon. So we appreciate your endless support and thank you for playing a very key role in supporting us throughout our journey thus far. We would like to thank you for taking your valuable time, effort, and consideration in the investment and nurturing and proper establishment of the future of pathology and laboratory medicine. It is not only an act of success, but one of greatness, showing us the path that you have walked. Last but not least, ladies and gentlemen, I cannot end this event without thanking you all for accompanying us this afternoon, and for making our event a success. We look forward to your continued support. All the best in your future endeavors, and for the students, all the best in your examinations. This marks the end of our presentation. Please don't forget to fill out the feedback forms, and good evening all.
Good evening.